Any technical difficulties, it will be posted shortly on our website. You may know that you're on your webinar control panel that all of you are currently muted. That means that you can hear us, but we can't hear you. We do that so that there isn't a lot of background noise during the presentation. If you'd like to ask a question, please type it in the question box, and we will get to as many as we can at the end of the presentation. Today, Dr. Ron Thibert from the Dup15q clinic at Mass General Hospital is here to talk to us about seizures in Dup15q syndrome. And now I'll turn it over to Dr. Thibert.
Oh, thanks. Thanks to everybody for joining in. Hopefully this will make some sense. So today we're going to talk about seizures, and just to start from the very beginning, this is new chromosome 15, which everybody knows, and just to kind of go over some of the very basics. So this is the area that's duplicated, and for people with interstitial duplications, there's one extra copy in the chromosome, so you have this kind of red area here, and then a second one kind of attached. So that's one extra copy of the area. And for kids with isodicentric chromosome 15, there's two extra areas, so it's an actual kind of 47th extra chromosome with two of these areas. So the kids with interstitial duplications have one extra copy, the kids with isodicentric have two extra copies, which is why the way things present and the symptoms of it are a little bit different. They're typically more severe for the kids with two extra copies instead of one. And just to kind of go over the genes, I won't talk about all these because I don't know about all these. But the big gene is the UBE3A gene, which we think is one of the the main gene that's responsible for the symptoms in Dup15. But just I like the slide just because it shows there's so many other genes that are also duplicated that probably have some effect. And I think some of the biggies are these GABA receptor genes here, these ones that start with GAB. And really, GABA is a chemical that the chemical in the brain that kind of quiets things down and mellows things. And when that system is off, that's when you can get things like seizures, sleep problems, anxiety. So I think in both kids with Dup15 and also the kids with Angelman, which is kind of the opposite, it's not having enough of these genes, that transmission is altered, and so we see. I think that kind of adds to the whole picture, at least from my perspective, in the seizure end. Kind of why we see some of the things we see. So here's a karyotype of the isodicentric, and you can see over here with chromosome 15, there's that little extra chromosome. So instead of this chromosome, which has the P end and the Q end, there's two Qs. So you have the two 15Qs that when you get from mom, when you get from dad, and these two bonuses, these two bonus 15Q regions that you get from mom. And clinically, just kind of basically what we see is the majority of things are neurologic or psychological. So we see developmental delays, which are variable. Some kids can have pretty severe delays, some really much more mild. And typically all areas, so gross motor, fine motor, speech. Behavioral issues such as impulsivity or self-injury. We see a lot of anxiety. There's a high incidence of autistic spectrum disorder to varying degrees, some more severe, some very mild. Epilepsy is common. Poor sleep patterns are common. And low tone is a very big thing that we see early on. So sometimes that can lead to some orthopedic issues. And then kind of outside the brain is GI dysfunction, so constipation, reflux. But really there's so many nerves in the belly and the stomach and the intestines that even though it's a different organ, we think that the brain is kind of involved and why that's an issue. And then looking at the case of the interstitial duplications, here's a nice picture from Nora and Larry's paperback from 2013. Again, so since it's one copy instead of two copies, it's the same kind of issues, but usually just much more mild. So just some subtle facial features that are a little bit different. The autism spectrum is of varying degrees, so that's the most common presentation, but it's usually mild. There's often behavioral issues with the anxiety more common than the self-injury or the irritability. Seizures are reported but not common. They're probably 10% or less. We'll talk about that a little bit later. Sleep dysfunction, again, can be present just like in the kids with isodicentric, and also GI dysfunction is common. We're in the process of trying to publish a study looking at it, and really because of the interstitial duplications tend to have as much constipation and reflux as the isodicentrics. So just a quick background on our clinic. Because of these issues, this is kind of how we built our clinic. So everybody sees me for neurology and epilepsy. Then we also have psychiatrists, neuropsychologists, sleep doctors, and again a GI person just because of all the GI issues. And then as needed, we can do consults for orthopedics or physiatry and ophthalmology if needed. And then also if people want, we can do PTOT, speech or augmentative communication. Those are typically done locally, but we can get second opinions here. And then just some background. This was the first clinic for Dup15. We started in late 2009, early 2010. So it's been a good 4 years now, at least, almost 5. Partnering with the Dup15 Alliance since the very beginning, and we've seen actually over 70 families, or probably more like 75 families. Just saw one today from Europe. Those families have kids with isodicentric, the other 2/3 being either interstitial or more of the edge duplications, which I'll talk a little bit about at the end. Families from all over the country as well as other countries now, and range of 3 months to 24 years. But we actually recently saw someone in their 30s, so we're starting to see a few more adults and a little bit older people. And that's Mass General from above. So getting into the epilepsy itself, just thinking about seizure types. So that's one of the confusing parts is when we talk about different seizures and different kinds of epilepsy, the seizure types are actually what the seizures look like. There's lots of different types of seizures, and the easiest way to kind of sort them out to start is focal versus generalized. So a focal seizure is a seizure. They used to be called partial. They keep changing the names every couple of years. So it used to be called partial. Now they call them focal, and that's a seizure that just starts from one part of the brain, and they can either just kind of stay in that part of the brain or spread, and then to give you a bigger seizure. So again, these are kind of older terms too. Sometimes they call them simple or complex. The simple partial or simple focal seizures is when you don't really have any alteration of consciousness, you're wide awake, you're alert. The complex partial or the focal are the ones where kids are either totally out or just not quite 100% aware of what's going on around them. And then the secondary generalized is when they start in one spot and then spread to the whole brain and cause a larger seizure involving the whole body. Then there's the generalized seizures, which kind of arise from the whole brain at once. So there's a bunch of different types of generalized seizures, which I'll talk about later. But sometimes, yeah, so I'll get into that in a little bit. But focal is just coming from one part of the brain. Generalized is kind of the whole brain seizing at once. So that's kind of the best way to initially think about seizure types. And this isn't I have a better slide that I need to substitute in. But this is an EEG, and so left side, right side, right side, kind of goes front to back. And this is hard to see, but you have to take my word for it. This is a seizure here. So it's a seizure starting from one part of the brain and not the whole brain altogether. And so this person who had the seizure was still awake and looking around, just wasn't really quite herself. So that's kind of what a focal seizure is. And the generalized seizure, this is one we'll see other. This is one example. As you can see, the whole brain is kind of seizing at once. So the whole brain's affected. That's what we call generalized. So in Dup15. The question is it a generalized epilepsy, kind of like Angelman syndrome, where we know it's generalized and the whole brain's always kind of going at once, or is it more multifocal? And what we think is that it's a multifocal epilepsy, so that there's various areas in the brain that can cause seizures, so not just one focus that can cause seizures, but lots of little areas around the brain that can cause seizures. And then sometimes if the seizures get severe enough, those little areas of focal seizures can all kind of get together and make like a bigger area of generalized seizures. They can kind of, when the seizures are severe enough, they can kind of join together and kind of all go at once and make it more of what we call like a secondarily generalized epilepsy. So we think at the root of it, it's multifocal, but that it can become generalized when it's more severe. And so what we see, and I'll talk about it as we go through our survey and whatnot, is that we really have kind of almost two populations of kids with seizures in Dup15. We have the ones that the seizures either stay focal or multifocal, so you get kind of the real kind of mild, easier to treat seizures, just kind of some staring spells, maybe some facial twitching, really not that hard to treat usually. And then you have the kids where they secondarily generalize, and then you get the really tough to treat seizures like tonic seizures, spasms, like the really tricky ones. So and unfortunately we can't predict based on genetic reports what kind of kids are going to fall into what category. It's something we always think about and we're trying to figure more about. But what we see is that just some kids just do much better and have either no seizures or very mild seizures, and the ones they have might be just like really brief focal seizures, and then ones that have just dozens of seizures a day, just spasms, head drops, tonic seizures. So why some have one kind and why some don't, we just don't know yet, but there's lots of people thinking about it. Some of the evidence as to why we think it's multifocal. On the we just published a study a couple months ago, actually, that just came out, where we looked at 11 MRIs, 9 kids with isodicentric and 2 with interstitial duplications, and 8 of the 11 had we call hippocampal malformation, so part of the temporal lobe, and I'll show a picture in a little bit. Not so much that it was had like severe abnormalities, but just wasn't quite rotated the right way. It's just kind of slightly abnormal, and so and that really matched up well with the paper that came out in 2013, where there was a neuropathologist that looked at brain tissue under a microscope and found that there were little abnormal areas here and there throughout the brain. So not big enough really to see on MRI, but that he could see on under a microscope. So between the MRI findings and the pathology findings, it really kind of matches nicely that there's little areas of abnormalities here and there that can cause seizures. And so, like, here's an example of one of the MRIs, and on this side you have a nice kind of normal looking hippocampus. That's where the hippocampus is, kind of a little bit deeper down, kind of in the middle. And then this one's just a little bit smaller, and this is probably a little better slide here. Here you have the nice healthy hippocampus here, and then over here, this one's smaller. It's brighter. There's this white stuff around it, which is extra fluid, meaning that it's just kind of shrinking down. So there's, you can see in some kids an actual, kind of abnormality. And we think that these can get kind of smaller and more shrunken down with repeated seizures. But what we're seeing in kids that don't even have any seizures is that these structures are somewhat abnormal to begin with, not grossly abnormal, but little subtle abnormalities that kind of tell us something's going on focally. And so kind of the big thing that we did a seizure survey back in 2010. It was published a couple years ago, actually 2013. And some of you who are listening may have taken part, if so, thank you. But we actually got 95 responses from families, which is great. It's the biggest the biggest survey that anyone had done so far. And of those 95, 83 had isodicentric, and with 63% reporting seizures, 81% with multiple seizure types, and 42% of those that had seizures having spasms. So with this study, though, there's always some bias. So most people, it was open to anybody for people just kind of to write in and say that their kids or family members didn't have seizures. But there's going to be a little bit of a bias to people whose family members had seizures to fill it out. So that 63 is probably a little bit high. Most reports are around 50% or maybe 50 to 60. So that may be slightly elevated from what we really see. But kind of getting back to the focal seizures, in this study it was 40% of people with isodicentric. And again, it might even be higher with the people with more severe seizure types, more likely to fill out the survey. But 40% with those with, not of the whole population, but of those only with seizures had focal seizures. And really with focal seizures, it depends on what part of the brain it comes from. The most common thing is just kind of staring, and you might see some chewing behaviors or some blinking behaviors. Really easy to confuse for an absence seizure. But depending what part of the brain is, if it's in the temporal lobe, some people may say that they get a sensation of fear or a strange smell, because that's what that part of the brain does. If it's in the back of the brain, what we call the occipital area, you could sometimes get these weird visual changes because that's the vision part of the brain. So depending on what part of the brain is affected, that's what happened. If it's in the frontal or the central region, that's where your motor area is. That's the part of the brain that helps you move. So you can get some shaking, but it would just be like one arm and one leg, or your arm and your face on that side. So again, just coming from one part of the brain, and then depending what part of the brain it's from is what kind of symptoms you get. Now the generalized seizures, most of the kids that responded to the survey had generalized seizures of some type, and 81% overall that responded to the survey had multiple seizure types. So the other biggies are tonic-clonic, tonic, myoclonic, atonic, and absence, and I'll kind of go one by one through those. So generalized tonic-clonic, that's what most people call grand mal seizures. So kind of what most people think about when they hear seizure, it's kind of head back, shaking of all four extremities, drooling, sometimes eyes roll back. And the reason it's called tonic-clonic is the tonic is the stiffening part, and then the clonic is the shaking part. And if anyone has a seizure like this, you're going to be tired afterwards. We call that postictal. It kind of just means after seizure. So there's usually fatigue, confusion, and the longer the seizure, the longer the fatigue afterwards. So sometimes tonic-clonic seizures can be, 10 seconds. Sometimes they can be an hour. Most seizures last 2 to 3 minutes, or 1 to 3 minutes. So seizures more than 3 minutes are rare. Seizures less than a minute are less common, but sometimes we see really short versions of these, which is, the shorter the better. And then atonic seizures. So these are called drop seizures, is kind of the more kind of famous name. So atonic just means no tone. And so the most common is head drop. So just kind of a quick drop of the head straight down, no movements of the arms or the shoulders, just a quick loss of tone in the head and just kind of drops forward. But if it's more severe, it can be a whole body drop. So sometimes kids, their whole body can drop down, but more commonly they're milder, they're just the head. But if they get severe enough, the kids can their whole body can drop to the floor. And then tonic seizures are kind of like the tonic-clonic, but without the shaking part, so just stiffening. And it's usually several seconds. It's usually not more than, typically it's 5-10 seconds, but it can be as long as half a minute or a minute, rarely. But these seizures tend not to go very long at all. The vast majority are a minute or less. But tonic seizures are tougher to treat, and they're the one seizure type that if you see tonic seizures, it's going to kind of indicate that the whole epilepsy in general is going to be harder to treat. Typically focal seizures, head drops, and sometimes those aren't so bad. When tonic seizures get involved, then it usually becomes a little bit trickier to treat the whole epilepsy in general. Myoclonic seizures are a little less common, but we still see them, so very brief contractions of muscle groups. So really just a quick jerk of the extremities. So like towards the end of the lecture, if anyone's getting bored and they start nodding off and then kind of your head goes down, then jerks back up, that's a myoclonic jerk. And we all do it in our sleep. We all have myoclonic. So if you kind of that dream you're falling and then you just like you can feel your whole body just jerk and it wakes you up, that's a myoclonic jerk. But these kids that have myoclonic, that's normal in sleep when having these big episodes of myoclonus during the day. That's what's abnormal when you're wide awake, so those can be myoclonic seizures. And then the absent seizures, there's typical and atypical. In Dup15, the seizures are usually atypical absent. So typical absent seizures are the kind where it's just a quick loss of consciousness, kids are out for a few seconds and pop right back to where they left off. The atypical absent seizures are longer. Kids can be partially aware, so if they're like walking across the street, they can just kind of keep still walking across the street. Sometimes they can respond a little bit, and those are the kinds that are seen in the kind of mixed seizure disorders, such as 15q. And then infantile spasms. So really, you can get spasms at any age, and kids with isodicentric can and do get them at any age. They're called infantile spasms. They happen in the first year of this, so kind of that's why they're infantile. But at least in our survey, 42% of the kids with seizures and isodicentric had spasms, and 27% of the whole population that took the survey. So those numbers are probably a little bit high, again, because it's a survey and you're going to have more people with more severe seizures answering. But it was still one of the most important findings of the survey because there's a few genetic disorders, tuberous sclerosis being another, that spasms are common, and so really, if spasms are there, it can really help kind of, lead to early diagnosis. And just knowing that 15q is there, it helps families kind of look out for spasms earlier. So knowing that is really important. Because with spasms, the quicker you diagnose it and the better you treat it, the less of an issue it's going to be moving forward typically. And so we typically see these in infancy, and it's really just it can either be kind of flexing forward or extending backwards, but it's a really quick jerk of the head going forward and the arms going forward. That's what separates it from atonic seizures. With the head drops, it's just the head going down. With the spasms, the head kind of gets forced forward, so that's a little bit hard to figure out, but the arms get forced forward as well. So if there's arm movements with these head drops, they're more likely to be spasms probably than atonic seizures. And you can see a subtle difference on EEG. So if to really kind of, if there's any confusion, you get an EEG while they're happening, and that can really help. But typically 4 to 8 months is the classic for any infantile spasms. In this survey with the isodicentric folks, it was 6.5 months was the average age of onset, so pretty classic. But then these spasms can come back later on. We've seen a bunch of kids at 7, 8, or 9 where they've come back later, and sometimes it's easy to misdiagnose these when they come back at 7, right? They look like head drops or maybe myoclonic seizures, but they're really spasms. And when we get into the treatments, you'll see that the drugs for spasms are a little bit different. So that's the important reason to kind of differentiate. So spasms can occur up to hundreds per day. They typically occur in clusters with variable spasms per cluster, and they can be run around by noise. So they'll happen or else on arousal, so kind of waking from sleep. Especially if you wake a baby from sleep, then that's when you can really see a big cluster of spasms. There's a classic EEG finding called hypsarrhythmia, which you don't have to have. It just means very high voltage EEG with lots of spikes. It's kind of a classic thing when you see it. That's most common in the first year of life, but you don't have to have that to have spasms. So it's still really a clinical diagnosis if you see it. And then there's this, I'll talk a little about this too later. There's this kind of LGS is a central Lennox-Gastaut. There's this really kind of tough Lennox-Gastaut-ish type epilepsy that we see in just a small group of the kids with isodicentric, and it's. But then some will also have some atonic or generalized tonic-clonic. And these kids just really don't respond well to medicines, and the seizures can be really, really hard to treat. And there's some very unique EEG patterns we've seen in some of these kids. But why there's a small group that have these really tough seizures where others might just have only focal, or maybe focal plus some head drops, or no seizures at all? Again, it's really not clear, but there is this subset where their EEGs are very unique and all look like each other's, and the epilepsies are the same type of seizures, really spasms and tonic seizures kind of headlining it. And so here's just this is from the survey. Just kind of what's really impressive is that the tonic-clonic seizures were the most, which we typically expect, because seizures can kind of generalize and move into that. But then the next most common, 42%, was spasms. So that's really, I think that was one of the most important findings of the study, was just to see how frequent the spasms were in these kids. And this is just from our clinic, so these numbers aren't going to be accurate, because most people that come to clinic, they come here because they have seizures, so it's not going to be an accurate representation. But just to kind of look at the kids we had in the first, I would say this is the first 50 or 60 kids. We haven't really updated it since we presented this a year ago, but we had 36 kids with isodicentric, and what was interesting was that the 89% of boys had seizures, but only 60% of girls. So whether that was just a random thing with these 36 kids, or if over time we're going to find that it's a little harder in boys, we don't know. In this small population, it was a little bit more, and the onset was earlier. So usually earlier onset means more difficult to control seizures. So it'll be interesting to see over time if that bears out, or if it's just one of those rare things where that's how these kids were, but then like the next 60 we'll see that the girls have a little bit harder. 32 out of 36% had some sort of autistic spectrum disorder, with 42% being nonverbal. But again, these are the kids that have the tough seizures, so that's not going to be the actual number for the whole population. 81% had seizures, so kind of way above our estimates of that, kind of 50-ish%, 50 to 60%. And then 24% of the kids that we see had spasms as well, 5 boys and 2 girls. And then out of that, 7 had this really difficult syndrome with the spasms, the tonic seizures, and the really refractory epilepsy. And this is just an EEG of what it looks like. So this is an EEG very much not hypsarrhythmia, and you have to trust me on that one, but really the EEG it's not high voltage, it's not chaotic, it's not at all hypsarrhythmia, but then you have this little burst of kind of slowing and some spikes, and this little flattening of the EEG just kind of gets flat for about a second, and that's where the spasm is. So just looking at, this was a 7-year-old boy, just looking at a small boy with, kind of the head going down and this kind of background EEG, you wouldn't think spasms, but that's what he was having, and so that's really why kind of being aware of it and looking for the diagnosis is really important, because the sooner you see it and diagnose it as spasm versus head drop or myoclonic or whatever, the sooner you can treat it with something that's really appropriate for spasms. And this is an example of a tonic seizure, which really looks the same, which kind of tells you why they kind of go together often. It's this kind of big thing of slowing and then flattening. With a tonic seizure, it flattens for several seconds. That's about 5 seconds of flattening there. So again, whenever you see the EEG kind of flatten like this, again, generalized because it's the whole brain that's flattening, but these kind of flat areas, for whatever reason, these kind of seizures are just much tougher to treat than the other types that we talked about. And as far as status, so status epilepticus it depends on the definition, but one of the most kind of accepted definitions is 15 minutes of just kind of constant seizing, or frequent seizures without return to baseline between events. So some people will say up to 30 minutes. It used to be 60 minutes, but now some people even say 5 minutes. So the reason we say 5 minutes is kind of what I said before. When there's, most seizures last 2 to 3 minutes. So if it gets to 5, we say, well, that's the time to give the diastat or the Valium or the Ativan, whatever you're going to give, to kind of give the rescue medicine, because most seizures stop by 3. So if it goes 5, that's not the reason we say give medicines at 5 isn't because that's when there's going to be any sort of brain injury or bad things happen at 5 minutes. It just means that it should have stopped and it didn't. So that's when we start treating it. And then in the survey we did 17% or 33%, 17 of the kids with isodicentric had status, and there were no kids with interstitial duplications that had gone into status. And of the 9 that gave us really good detailed answers, 8 had fewer than 10 episodes, with 2 of 8 only having a single episode of status. So again, with these numbers likely inflated due to the just nature of the survey, it's not as common as some other genetic disorders where we see a lot of status. So it does happen, but it's not super common. And the non-convulsive status, so this is a kind of a tricky one. That so non-convulsive status epilepticus is basically when you don't see a lot of clinical seizures, but you see developmental regression. And then when you check the EEG, there's just lots of abnormalities, lots of spikes. So really, kids with isodicentric, they should not go backwards. They should not lose skills. So any sort of quick regression, like over the last few weeks, few months, they're not talking as well, not communicating as well, any sort of regression like that. It's always good to check an EEG to make sure there's not any big changes on the EEG. And sometimes we'll get the story, we'll get an EEG, and we'll see some real subtle little head drops or some just stuff that's really hard to see unless you actually have a camera on it. You're looking at the EEG, looking at the the little guy or little girl with the EEG on, and try to figure it out. But it's really important if there's any sort of regression to check an EEG and make sure it's not epilepsy related, because that's something that we can actually where we can intervene and do something and make things better. So in the survey, 33 out of 52 reported some regression, with 20 saying it was clearly due to seizures. But in some of those kids, it was they were clearly having a lot of seizures. And we know when kids are having a lot of seizures, development's not going to go as well. And then SUDEP, this would be a whole webinar on its own, but basically sudden unexplained death from epilepsy. So the cause is really still not well understood, whether it's the brain, the heart, the lungs, the combination of the 3. It appears to be a little bit more common in kids with isodicentric, or even 15q in general, than in the general epilepsy population. And in the study that we had, 4 out of 52 reported deaths believed related to seizures. 1 was clearly from status. They just kind of started seizing and didn't stop. And the other 3 weren't explained, so we assume those were SUDEP. But again, there's a whole, that's going to be a whole talk on its own, and it probably will be at some point, but I won't get into it too much today. And then the treatments for the seizures. So we usually start with medications, but we also have dietary and surgical treatments. And for spasms, so there's 2 medicines that we use for spasms that are better than any others, and they're medicines that we really don't use for any other seizure type. So one is vigabatrin. Her name is Sabril. It's a great spasm medication. It's one of the it's one of the 2 best we have for people in general, and also good for partial seizures in some people. The risk of Sabril is that it can constrict your vision, and about 30% see a little bit of a decrease in their visual field. So not how well they see, but just kind of how much to the side they can see. But it's a pretty low risk, and those that get it, it's usually very mild. Then ACTH, it's injectable, but it's kind of a pre-steroid. So when you take ACTH, you get the same side effects you get from steroids. So increased blood sugar, increased blood pressure. You can get weight gains because it's steroids, and it can suppress the immune system. You can get infections. So there's potential side effects, but if it works, it can really be life-changing. And then beyond those 2 medicines, ketogenic diet is an excellent treatment for spasms. And then in terms of the other medicines, clobazam, which is just recently available in the U.S., otherwise known as Onfi here in the U.S., and then the other broad spectrums, and I'll talk about those in a little bit. But looking at the study, so this may be kind of confusing. So this is this column over here is those that had 90% or more improvement in spasms, and this really tall line here is the ACTH, and this is the vigabatrin group, and this is the group over here where it says worse, that some were better. I mean, the ones that got worse with the medicines, and so there's actually no line for the ACTH, and then a little bit with vigabatrin. So really, it was really striking how much more effective the ACTH was than the vigabatrin. And one of my thoughts is the reason is the vigabatrin works on GABA, and the drug companies very cleverly put the word GABA in all the GABA medicines, so vigabatrin. And really the GABA genes are those, again, going all the way back to the beginning, the ones that are duplicated. In these kids, they have 3 copies of these genes for GABA receptors. So it almost seems like there's too much GABA, or just because the cell system's off. I think the GABAergic medicines just don't work as well, which is why the ACTH seems to be, or oral steroids seems to be the best way to go for spasms in these kids. And this is a little bit misleading, but this was for the whole population, this little pie chart. This is so those that had 90 to 100% improvement on the first medicine, 50 to 90, less than 50, no change really, and then those that got worse. Again, it depends on what medicine you choose. If you're picking the wrong medicines, it's not gonna help. But I think this 24% is misleading in that there's, again, those 2 groups, and so you have the group of kids that have the spasms, tonic seizures, that whole really tough group. For those, the number is really probably pretty low, probably 10% or less for really getting the first medicine to work. Whereas for the kids that only have the focal seizures, that other group that I was talking about, they're probably more like 50%, kind of the same as the general epilepsy population. So I think instead of really looking at the whole group as having a 24% response rate, there's going to be one group that has a really low response rate, probably 10% or so, and another that's probably more like 50%, and then when you add them all together, you get this 24% response rate. But it was really kind of hard to tease that out from the survey, and also we didn't know as much then as we know now 4 years later. So we're looking at that number. I think it really represents kind of an average of 2 distinct groups, one that has a very low response rate, one that has a pretty typical response rate for epilepsy in general. And looking at the medicines, there's broad spectrum, and then there's the focal / tonic-clonic. So these medicines over on the right, the phenobarbital, xanthins, carbamazepine, oxcarbazepine, gabapentins, pregabalins, those are medicines that are good for focal seizures, and also the seizures that start in one place and spread to the whole body and cause a tonic-clonic. But they're not great for the tonic seizures, the spasms, the atonic seizures, the atypical absence. So for kids that just start having focal seizures at age 10, for instance, and that's all they have is just clear, like, left temporal seizures on EEG, any of those medicines are fine. But for mixed seizure types, these aren't the best because they're not good for those other seizure types. So for the the tonic, the atonic, the atypical absence, then it's this group, the broad spectrum medications. So Depakote being the oldest, still effective, but does have a lot of side effects. Felvital, which isn't really used very often because it can have some really significant side effects like liver damage or your blood counts dropping way down. So those are rare, and actually the only cases that have been really serious have been in adults when it first came out. So it can still be it can still be used, but we usually use it kind of farther down the line because of all the concerns. And then the ones that we use most are kind of the ones from Lamictal on down. So lamotrigine or Lamictal is very good. Zonisamide, Topamax, Keppra. So these are all kind of the classic standbys that have been around since late 90s, 2000. And then there's 3 newer medicines which I've actually had some good luck with. So clobazam is in that family, the benzodiazepine family, but it's a little bit atypical. So it tends to work. Oh, that's an old slide. Sorry, it says Ferzium. I should say Onfi. That was the Canadian name. But there's still some thought about whether how much the clobazam will work. We have been trying it in some kids with mixed results. But these other 2 new ones, raffinamide and lacosamide, have had really good luck with, especially Vimpat or lacosamide. And it's not just the 15qs, but other kids that have had tonic seizures and spasms. Vimpat has seemed to work really well. There's really nothing in the literature about it. It's just when you kind of get to the point where you've tried everything for someone, you try the new medicines that come out. And when Vimpat came out, we really started having good luck with it in some kids. So, after the first, the Keppra Lamictals, which you usually start with, those the one I've been kind of using most. And of course, we have no data from the study because it came out in 2011, so it was after the study started. Refinamide had just come out, the Banzel, so we only had maybe seen a half dozen kids that had been on it. So we didn't have great data on those two just because they were so new, and same thing with the clobazam. But the newer medicines can be have really been pretty helpful in a lot of kids. So those are kind of so this broad spectrum category is the one we typically use first, because if there's multiple seizure types and not just focal, you're going to need something like this. Whereas if you know something's only focal, you can add in something like a Trileptal or a Tegretol or something like that. And this is just kind of a quick, so again, the numbers are small, 18, 12, 23, so it wasn't a big enough study to really get a lot of good information, but just kind of a quick snapshot. Banzel, only 6 kids, but 5 out of the 6 had a really nice response. Nobody got worse on it. Interestingly, the Klonopin, so again, the benzos, so Klonopin, Ativan, Valium, those kind of medicines, because they increase GABA, we think that they're not as helpful, and in this group, about half the kids got worse on Klonopin. Nobody really had significant improvement with it. That doesn't mean that they're not the right drugs to stop a seizure, so they're really the only ones that can quickly quiet something down. So if someone's having a long seizure, the Diastat, the Valium, the Ativan, even Klonopin is still ideal for everyday use, so we typically don't use them kind of every day. And then this is kind of, again, showing that the Banzel was really well tolerated by everybody. And kind of usual, we saw the Banzel people tolerated, Keppra people tolerated, Lamictal. Keppra, useful, but again, it kind of makes kids kind of cranky. So, but it's still one of the best medicines we have. So kind of mixed results, just not really big enough numbers to really get good ideas of how well tolerated the medicines were. But we know that most of them are pretty good. And then just going into, I have some slides on this, but I won't go into too much detail, just so I don't want to, but they'll be here in case anyone wants to go back and read them. The ketogenic diet's about 100 years old, but with evidence going back hundreds of years. And so they used to starve people when they were seizing. They wouldn't let them eat for 25 days, and they would stop seizing. So we don't do that today for obvious reasons, but what the ketogenic diet does is tries to trick the body into making people think that it's starving. So when we starve, we just burn the fat we have on us. And so what the ketogenic diet is just giving kids lots of fat and some protein and very little sugar. And so that keeps your blood sugar down, keeps your insulin levels down, and the brain burns fat instead of sugar. And we don't know why, but that really makes the brain less likely to seize when it's using fat instead of sugar. So we don't fast kids anymore. We admit them to the hospital because we want to monitor the labs pretty closely for a couple days. They usually stay 2 nights, and we do all that. We just convert the whole diet over that first day, and then they go home on the special diet. And then we monitor pretty closely. If they're on Topamax or Zonogram, that can make things a little bit worse, because now you're getting all these fatty acids in your bloodstream, so you get a little bit acidotic. So there's medicine that can fix that we start. And then the LGIT, which stands for low glycemic index, it's kind of a milder version of keto. So it takes out that same principle that you're keeping the blood sugar low and stable and the insulin levels low and stable, but you're not going so crazy with carbs and fat and all that you're burning fat. You're still burning some carbs, so you don't get acidotic. You don't get all those fatty acids floating around. You get some, just not a ton. But it's easier. The ketogenic diet is less than 10 grams of carbs per day, whereas low glycemic is 40 to 60, but it's good carbs that don't raise your blood sugar that much. So we don't even have to admit kids. The monitoring is less frequent, and you can even go to restaurants with it. You don't have to weigh things. It's just kind of choosing the right foods and kind of in the right proportions. So in general, for low glycemic, about a third is not effective. Either it doesn't work, or people just don't tolerate it, so they have to stop it. About a third we see 50 to 90% reduction in seizures, which is great. And then about a third of kids, 90 to 100% of reduction in seizures. So some are even seizure-free. It can take a couple of weeks to kick in, but sometimes it might even take 2 to 3 months for the body to really kind of convert and start using fats instead of carbs for its energy. And we did one study on the Angelman folks. So kids that are either missing or have a mutated gene in 15q, and we actually had really good results with them, with 4 to 6 having 90% or more seizure freedom. Only one really not having a great response, but later on did have a good response. So So if that's any indication, that this could potentially be very good. We've only put a couple of kids with 15q on the diet so far. One on low glycemic that didn't have much response, but was having spasms. So we know low glycemic's not the best for spasms. Really, keto is more important. And then one kid on keto who did really well. So it could potentially be a nice option. And then surgical options. So the kind of the main surgical thing is resection. So you go and you cut out the part that's seizing. And so some kids with Dup15 will have actual abnormalities on MRI you can see and potentially cut out. But because there's little abnormalities all over the brain, the odds are if you cut one chunk out, other ones can kind of pick up where it left off. So we typically don't do resective surgery on kids with genetic disorders because all their brain cells are going to have that same abnormality in it. Corpus callosotomy, if the drops are super severe, you can kind of cut the little piece that connects the right to the left, and that can kind of slow the spread of seizures, which makes things a little better. The one that we typically, and that's, again, we rarely use that, the one that we would actually use in some cases is a vagal nerve stimulator. So it's a little machine that you kind of put under the skin in the chest, and then it wraps around the vagal nerve so that you have two big nerves that come from the brain that go down to the heart and the lungs and the belly. The right one mostly sends fibers down. The left one sends fibers up, so they wrap around the left one. And it sends a pulse up to the brain. And again, it's kind of like the diet. We don't know why it works so much, but 50% or more of kids can have a 50% seizure reduction. So it's not curative, but if you're having just tons and tons of seizures every day and nothing's helping, that can really decrease them significantly with very little risk of anything else. So that's kind of what I just talked about. So kind of in summary for the treatments, the broad spectrum agents are first line, so I've really had good luck with. So Keppra and Lamictal are kind of the two that we use most just because they're safe and easy and been around a while. But beyond that, Vimpat's been one that I've had a lot of good luck with. Banzel has been helpful. And again, there's really nothing in the literature. The one thing that we really have is the seizure survey we did, which is good, but again, it was small numbers. It was before Vimpat came out, before Onfi was approved. So really, we need to look into that more, and as time goes on, I'm sure we'll be collecting data in the clinics and kind of see what's helped, what hasn't helped. For Tegretol and trileptal medicines that kind of notoriously make generalized seizures worse, these can be effective in kids with 15q, so that kind of tells us that it's a multifocal epilepsy. It's just that if you're seeing that secondary generalization, they're not going to work as well as the broad spectrums, but they typically don't make kids worse the way they would with an Angelman syndrome or something like that. So for spasms, ACTH or oral steroids like a prednisone seems to be much better than vigabatrin, which is a great medicine in general, and it's a drug of choice in tuberous sclerosis. But in 15q specifically, I think it's because it's a GABAergic kind of medicine, which doesn't seem to work as well as the steroids. The benzodiazepines relatively ineffective. So Ativan, Klonopin, Valium, we try to stay away from those on a daily basis and just use them for emergencies. They still work really well for stopping a seizure emergently, but having kids on everyday Klonopin, everyday Valium, we try to avoid that if we can. And then dietary therapy is very promising. Definitely, kind of the thought is if 2 medicines or more fail, that's officially refractory epilepsy, and that's when you start thinking about options like diet or surgery or that kind of thing. In kids with genetic syndromes, diet as opposed to surgery, but that's when you start to kind of think outside the box a little bit. Like, do you go to medicine 3 or do you start thinking about something else? And a lot of those kids' diet can be really helpful. And just looking at some EEGs, so nearly all the EEGs in isodicentric, and it may even be the vast majority, they have what we call excessive beta activity throughout, and I'll show a slide, but it's just really fast activity that kind of sits on top of all the other brain waves, and there's nothing bad about that, but the interesting thing about the beta activity is that we typically see that in kids who are on benzos, so kids that are on Valium, Ativan, kids that are on phenobarb, we see a ton of that beta activity, so we know they're on those drugs, whereas most kids with isodicentric tend to have that just naturally. So again, that's kind of a clue that there's probably something wrong with the GABA system, and there's a little too much or whatever the issue is, kind of there in the brain. So that's sort of the classic finding that we've been seeing. The other thing is that subset of kids that have the really tough EEGs with the tonic seizures and the spasms, they have this really kind of, they have these three patterns in sleep that we've been noticing that we're going to write about. These bursts of these really high amplitude 12 to 16 hertz polyspikes, some alpha delta sleep, and sleep activated discharges. So the alpha delta I don't actually have a picture of, but what it is delta is slow and then alpha is more kind of like a regular speed. So delta's like 2 to 3 bumps per minute or bumps per second, and alpha's like 9 to, or like 8 to 12 bumps per second. So you see the alpha sitting on top of the delta, which is not a common finding, but we've seen it in several kids with isodicentric. And then sleep activated discharges just means that they're not that much awake, but then they become really frequent when they're asleep. And so here's a slide of the beta activity. You can just see all this really fast stuff on top of the other waves. It's an even better one. So you see the normal waves, but you see all this just fast. And so if you show anyone that reads EEGs, this EEG, they look at it and they say, oh yeah, that's a kid on Valium or that's a kid on clobazam. But really, this kid was on any of those medicines that should cause it. It was just having the isodicentric. And these are the big. I had to kind of turn the volume down so you can see it, but these just big, tall, fast spikes during sleep. This was one person, this was another person, same exact looking EEG, and very unusual. We don't see this kind of EEG in a lot of people at all, but these kids with these tough epilepsies, they all tend to have the same looking EEG when they go to sleep. So I know we spent like 90% of the time on the kids with isodicentric, but there's a reason for that. The kids with interstitial duplications, from the survey, we had 12 responses. 3 had reported seizures. 1 was just a single, either absence or focal seizure at a young age, and this was an older child. 1 that had some absence and tonic-clonic seizures, and then 1 that reportedly had spasms, but spasms seem to be really unlikely in these kids. So the question was, was that where they diagnosed right? Was it really interstitial, or was it more of an isodicentric? But either way, it was. If you take out the one that had just a single seizure, there's only 2 out of 12 that had seizures. And then from our clinic specifically, we had seen 11 kids with interstitial duplications at the time. 9 of 11 with autistic spectrum, but only 1 was nonverbal as compared to the 42% of the kids with isodicentric. And only 2 of the 11 had seizures. Both were focal seizures. Both were on just 1 seizure drug and doing well. So again, the seizures are much more infrequent, and the ones that have them, they're usually really easy to I don't want to say really easy, but they're no tougher than anyone else in the general epilepsy world to fix. And none had spasms in our group. And then in the paper that Larry Ryder and Nora Hiraka and the rest of us helping them out from 2013, there were out of the 13 kids that had gotten EEGs, only 1 had discharges that looked like could cause seizures. So even though we didn't get a lot of seizure histories on those kids, only 1 had an EEG, which made us worry about seizures. So really, less than 10%. So when you look at kind of even though it's not a lot of data, the 12 from the survey, the 11 that we've seen, the 13 that Dr. Ryder's seen, there's the common theme is 10% or less, and the ones that had seizures, they seem like they're not these really difficult seizure types. They're usually the ones that respond well to medication. So that's why we didn't really go into a lot of detail with the interstitial duplication kids, because the seizures are pretty rare, and when present, usually not that difficult to treat. But the beta activity is still there. So this is a little guy with interstitial duplication. Again, lots of fast activity, just like the isodicentric. But otherwise, and again, you have to take my word for it, the EEG looks pretty normal under the beta activity. And then kind of looking at the edge duplication. So if you kind of go back, I won't go all the way back, but go back to that first slide that showed the region, the genes that are kind of outside that, what we call the critical region. So the ones in the 112 neighborhood and the ones in the 132 to 133 neighborhood. The question is how do those genes affect people when they're duplicated? And there's not a good consensus. There's lots of people that have these duplications that don't have any symptoms, but then there's some that do have symptoms, and the question is it just a random finding, or do they really cause problems? And I, at least kind of personally, I think that in some people it does, because I've seen a fair amount of kids with the 1.2 duplications that all kind of seem to have the same issues as the other ones, and kind of what we see is just is some sort of autistic spectrum diagnosis, but mainly very mild, just almost sometimes almost Asperger, but just a very mild autistic spectrum. Only 1 out of the 5 had seizures, and which could have been due to that or could have been random. And the two EEGs we had were normal, and we didn't see the beta activity because those genes that I was talking about weren't included in these duplications. So again, we don't really know a lot about these in terms of what it means clinically, but kids that we do see that have mild autistic spectrum disorders, there's a good chance that these genes may be involved in that in some way. But as far as seizure risk, we just don't know if there is a seizure risk with that or not. Because the genes that we think are really behind the seizures in the kids with the classic isodeccentric or interstitial are the UBE3A and the GABA receptor genes, and those aren't duplicated in these kids. So it's unclear if there's any seizure risk, but we do think that there probably is some risk of autistic spectrum type, mild autistic spectrum type issues. And then on the other end of the spectrum, the 132 to 133 kids, we've only seen a couple. They both were on the autistic spectrum. One did have seizures, but it was someone who was born very prematurely, so it's more likely the seizures were due to that than to the duplication. And again, we didn't really see anything too crazy on EEG. So this one's being looked at a little bit more, and there is some thought that there's a chunk, maybe like a 10% risk of some sort of autistic spectrum type stuff. But again, kind of like on the other edge, it's not everyone who has the duplication is going to have symptoms. Well, probably most won't, but in some cases, it could contribute a little bit. But again, the risk of seizures is very unclear, and as of now, we don't know of any definite risk of seizures with these duplications. And then this is our group from the clinic. So it's me, Heidi Pfeiffer, our dietitian, and then various group of neuropsychologists, sleep folks, psychiatrists, genetics, and we see kids and adults. We haven't seen many adults yet because it's kind of a newer diagnosis, so there's just not a lot of adults diagnosed at this point. But as time's going on, we're seeing more and more older individuals, and hopefully over time we'll get a better idea of kind of what happens in adults when they get to that point. I think that's all I had. If there's a few minutes for questions.
Okay, we've received a bunch of questions, some of them along the same lines. Our daughter is 9 years old with Dup15q and has not yet had any seizures. Is there a possibility of them showing up later in life? And another question along the same lines, how often do seizures not start until after puberty?
Yeah, no, that's a great question. So what we see in kind of the general autism population, and I think it really kind of the Dup15 just mirrors that beautifully, is that you see two peaks in seizures. You see the early peak, which is kind of 3 to 5, unless you have spasms, that's right away. And then you see a second peak around puberty, so 11, 12, 13. So there is a chance that seizures can still pop up, and we've seen a couple of teenagers that have had that. On the downside, there still is a chance that you can have that seizure with that second spike when you get into early teenhood. But on the positive side, it's almost always going to be just focal seizures, which is just so much more mild, so much easier to treat. I haven't yet seen spasms, head drops, tonic seizures begin that late. Typically, those are the ones that begin early. So the really difficult seizures typically start early on, and then just kind of don't give up. And then the kids that get through the early age, kind of the early years, and then get to that point seizure-free at 9, 10, 11. I'm not sure what the exact. I don't want to say it's 50-50 because it's probably not that high. But if I had to guess, you could say maybe like 1/3 yes, 2/3 no. But if the seizures were to start in puberty, we've seen a few teenagers who they've started at that age, and we've been able to get them all really well controlled pretty quickly. So again, it's a small sample, but that's the same thing in the general population of autism. The kids that start off young are more likely to have mixed seizure types and just tougher epilepsy, whereas the people that start in their teen years usually have easier to control seizures, and they often outgrow them as they get older. Like the kids that start at like 12, 13, 14, they often go away at 19, 20. So it doesn't. So even if they do come, there's no guarantee they're going to be lifelong. Most will outgrow them, and then and they're usually the easier type to treat. Can't say for sure, but so far I haven't met any kids who have started with really tough seizures later on.
Okay. Is the risk to have seizures correlated with the magnitude of the duplication?
Yeah, that's a good question. So we don't think so. So I mean, definitely it's isodicentric versus interstitial. Isodicentric, you have two extra copies. Interstitial, you have one extra copy. So the risk goes way up. But as far as kind of where the breakpoints are and the size of it and all that, so far we haven't seen a correlation with seizures with development. So we honestly we just don't know why some kids have it so hard and some kids have it much easier. And that would be the one thing if I could like just learn one thing and that we don't know already, that would be the one, like why. But we just don't know, and that would be amazing to know why. So you know, there's a lot of us thinking about it and brainstorming, but just haven't really figured out what it is. But yeah, that was one thing that I think actually Carolyn Shannon and probably a couple others looked at that a while ago and didn't find any difference in size. And then when we do the seizure survey, I know that Carolyn and Brenda looked at a lot of the genetic reports and nothing really stood out when they were looking at things. So I don't think you can tell from a genetic report how the seizures are going to be, other than just isodicentric versus interstitial, which we know there's a definite difference. But within the isodicentric folks themselves, it's the report, the actual genetic makeup just doesn't really tell us much.
Okay, the next question is, does the low glycemic diet have risks like kidney problems?
Well, that's a great question. So, so every diet has some risks. They're less than medicines. You know, you worry about kidney stones and whatnot if you're too acidotic. So, low glycemic, it's much less than keto. And really, if you stay on top of it and kind of keep checking labs regularly, and you find the acidosis, you treat it. Very, very rare we see anything. Actually, out of all the dozens of kids we put on low glycemic, I don't think I've seen any with a kidney issue. There's been a couple of kids with keto, but there's a lot more acid built up in the blood in the keto, so you really have to. That one's tougher. With low glycemic, it's possible, but very unlikely. The worst thing we usually see with low glycemic is constipation, which is often there to begin with. Then we make it worse with the high-fat diet, but that's not the the worst thing in the world. We can kind of help that with Miralax and increased fluids and that kind of stuff. But with the kidneys themselves, it would be not impossible, but really rare with the glycemic if monitored properly.
Okay. The next question is, can myoclonic seizures look like infantile spasms? Are infantile spasms always in a cluster, or can they be single spasms?
Yeah, good question. Yeah, they can be confused for each other, and so spasms are usually in clusters, but not always. You can have single spasms. For infants, they're almost always in clusters. It's rare that they wouldn't. In bigger kids, they're more likely to be single. But that's the thing. If there's any question, getting an EEG and really seeing it on video, and with the EEG running, so you can see electrically what it looks like when it happens, that would be that would really nail the diagnosis. So if there's any question, if someone is diagnosed with myoclonic seizures, but there's no question they may be spasms, the EEG would really help a ton, because we've had a couple of kids that have come down that have had diagnosed with atonic and myoclonic, and then we hooked them up that they were actually spasms. So they can look alike, but and it can be confusing. But really getting a good video EEG with the events and the EEG running, they look different on electrically, so you can really tell when you hook them up.
Okay, I think we have time for one more question. So, how does the onset of seizures at different ages affect IQ?
Oh, that's a good question. So, typically, the earlier the onset, the more it will affect things. As the brain's growing and developing, you want it to do that normally and not with all this extra electrical activity floating around. So, the later the better to start with seizures. The other thing too is how well you treat them. If they start early, but you can get them under control really fast, that's going to be much less of a problem than if they start early and then just don't get well controlled for years. So it's part of the age, but it's even more how quickly you can fix them, and also the type. So spasms and tonic seizures are the hardest. Kind of absence, myoclonic head drops are not as bad, and then the focal seizures can sometimes don't even have any effect on cognition or development. So it depends on the type of seizure. So the age is part of it, but then it's how quickly you can fix them, and then also what type you're having.
Okay, that's all we have time for today. A big thanks to Dr. Thibert for sharing his expertise with us. The recording should be up shortly on our website, and please take a minute to fill out the survey that you'll see at the end of the webinar and let us know what you think. Thanks so much for joining us.